Okay, good afternoon, everyone. This is Debbie Nadzam-Melnick, and this is the March 7th meeting of the VCSQI Person and Family Engagement Work Group. Attendees are all, or invited attendees are all listed in attachment A. Those are the point people for each practice that is enrolled. And just by way of reminder, I've placed the objectives of our work group here again to review the status of practice and the 6 PFE metrics and 3 assessment milestones related to person and family engagement. To review, understand, and adapt tools already available toward improving PFE within practices, and to share resources and learn from each other, including sharing of stories both within our enrollment group as well as across TCPI when those of you are willing and interested in sharing your stories. So first I just want to ask if anyone has any specific topics they wanted to bring up today. Anything else to add to the agenda? You can type it in the chat box, which you can access down at the bottom of your screen by clicking on chat and it'll show up. Or you can speak up if there's something you want to be sure we get to today. Okay, after a count to 7, not hearing anything, we're going to go to the next agenda item. I'm going to try to keep these calls a little shorter this time. There's no reason to think that we always have to schedule a 1-hour meeting. That's difficult for all of you to pull out of your daily schedules, especially when we ask you to do another one every month related to the opioid prescribing activities. So today I'm really happy that we have one of our practices willing to share what they are doing as it relates to engaging their patients, not practices, engaging their patients and family members in the care provided and working towards helping them understand lifestyle changes as necessary. Bakula Dave from Heart Care Associates, PC in Hopewell, Virginia, has some interesting strategies to share. So Bakula, I'm going to put up the document that you sent to me for people to see and for you to use as a speaking background. Is that all right? Are you on mute yourself? Bakula? I wonder if you should be unmuted. Don't show that you are muted from this end. All right, well, let's just jump ahead for a minute then. Maybe she had to step away. Just start talking, Bakula, when you are back and ready to go. No, is there something here in the chat box? How can we unmute? We are here. Look at the bottom of your screen to the lower left, and you should see both a little video cam and a mic. If you're muted from your end, it might show a line through it. Or perhaps your computer down at the lower right on the speaker, you might have a line through the speaker there. Okay, you're going to talk.
Maybe I use the phone.
Okay, we can hear you now.
All right. So anyway,
okay, I'm going to put the document back up then. Here you go.
Okay, so
maybe you can tell us a little. Will you tell us a little bit about the practice first, and then get into strategies?
Okay, so this is a cardiology practice, Heart Care Associates. We are in Hopewell, Virginia, and it's a solo practice. And so we've been in practice more than 20 years. So most of our patients, like we have a, like father and their grandparents, they all are our patients. So we have a very close community here, and so it is makes it a little bit easier to practice. The for when we came to the patient's family engagement, uh, uh, so we've been practicing like this before, but now we have since Medicare, it's a new strategy Medicare is using, so it makes it a little bit easier. We can tell patients that now Medicare has a new, um, uh, you know, like new technique to use, engage patient's family um, with in a care, and that most of the patients and their relatives like it. As caring is contagious, um, when we have a patient and a family member in the examination room, um, mostly their names are there. We make sure first thing that they are in their HIPAA notice. Their name, family person's name is in the HIPAA. Once they are in, the patient's approval that they can involve in their care, then we go with our strategy with the diet plan and then weight reduction and all, and the smoking sensation, and then medication compliance. But so family members, it becomes a little bit easier to get them involved because they have blood relation or a spouse, and so they do want to help out. But sometimes with the caretaker, it takes a little time to engage them since they are just paid. So maybe I don't know how this caretaker, the Medicaid has, like senior citizens, they have somebody like caretaker they call, that's med provided. The payment is provided with Medicaid, and they are there to help. They are there to help the patient. So when I talk to them, like for example, yesterday I had somebody said, "I just bring her here." So then I asked, but before I talked to her, I'd already talked to the patient that, do you want her? And patient said, ask her if she wants to help me. It would be easier. She's supposed to help me. So then I went and asked the caretaker, and she said, no, I just bring her. I said, what other things you can do for her? And then she said, uh, I'm supposed to do everything. Then I said, then I think patient wants you to come in the room. Do you want to come? And then, we have this program you want to participate. So it was a little bit hard. Yes, it's each patient will be different. Each caretaker will be different. And this is a long process. It's not that, okay, we are, you're going to, um, mostly we will have a success, and there will be a time that caretaker doesn't want to, but then we have to um, um, engage them more or like motivate them. So then yesterday I talked to that person. They said she was supposed to just saying I only drive her, but then eventually. So if we get help from Medicaid also, that okay, you are not just bringing them to the doctor's office, you also need to get involved. So it will be another helping hand we will get from Medicaid, because that's what I understood, that they are um, they're paid by Medicaid, and they're supposed to take care of them. So if we involve them, then actually after 15, 20 minutes of discussion, I was able to involve her, and she said, okay, she will keep track of whatever the diet, or that patient didn't had a weight reduction issue. Actually, we had to encourage her to eat more because she was losing weight. But she said, okay, she will make sure small portions, more, involved with her in the more food intake, and keep track of her blood pressure. And she didn't have a smoking. She never smoked, so she was fine. So each patient will be different, and we have to tackle differently with the but mostly so far, since we have tried last 2 months, I had more success than than not I mean, you have to, some patient, you have to work very little harder than talk to. And as I said, caring is contagious. So once that caretaker will start helping them, then the other patient also can, um, some patient cannot help back as a caring, but maybe a blessing, or maybe the relationship improves. That naturally, if somebody cares for somebody, it does, reciprocate in a positive manner. So the rest of the things are already on the screen, but it will be individual. And then this is a very good. But if we can get help from Medicaid too, whoever are the caretaker, we get about 40% patient comes with the caretaker. So I don't know, and they are assigned through Medicaid or somebody. So if it's a whoever is paying them, if they add that into in their job list or something, that okay, this can be that can be done, so that maybe we'll get us a helping hand in this matter. But otherwise, we talk to them like a small baby step, and like some small goals, that weight reduction, maybe by next visit, maybe 4 pound, 5 pound less. Diet, approach the healthy diet. Cut down the trip to the fast food, and a medication too, if they help them, um, uh, arrange the medication on a weekly base, and then make sure they have taken all the days. If they miss the dose, document it so then next dose is not missed. And for the family members, if they are not living with the patient, I tell them that, can you make a phone call, like when you talk to her, remind whether the patient had taken medicine or not. So that also helps. Just as some small reminders. And so there is someone who cares for them. That feeling itself makes them more compliant. And then we always encourage them to bring actual bottles to the office, so that way doctor knows exactly what medication they are taking. And we always encourage them, if anybody changes the medicine on them, please inform us. So that way there is no duplication of the medication, and there is that is the biggest help we can do, reducing the unnecessary cost into the health system. That so much misuse of medication, or because a lot of doctors keep on changing medicines, and naturally new prescription, the rest of the medicine are already wasted, and those are the things. So we try them to please inform anybody, and then we talk to the doctor the reason for the changing that medicine or something. And pharmacy, if they stay on top, that would also help, that because they are the one filling the drug. So before even filling, if they can check with a physician that what is the reason for prescription, or patient is already taking that, maybe they didn't bring the bottle that time. So there may not be excessive like hypertension medicine or excessive of cholesterol medicine or something like that. So involvement of patients, relatives, caretaker, it is the first step in the improvement of a health system.
Thank you, Bakula. How are your patients and family members reacting to this? Is this a document you give to them, and how do they respond?
Yeah, that's what I said. Most of them are very happy about that, and they said it's good. But as I said, caretakers or a couple of family members, I have to really, a different approach I have to use that, So it's just everybody will be different, but it is a very positive. At least patients are really happy about it, because you can see in their eyes, like, thankfulness that, okay, then they said, oh, the doctor is talking about her, and then making somebody else listen to, and then like next time they will come, I'll have questions for them that, okay, did she miss any dose? Do we have any improvement with the weight management? How is the diet going? You know, so all these things. So it is like it's a record keeping and tracking. So maybe not first visit, second visit, third visit. I'm sure we will have some success.
Okay. Do any of you listening have any suggestions or reactions or do something similar that you'd like to share?
Hi, this is Jenny. So did a patient engagement, but we used for our practice, we used work on dialysis patients, and some of them have catheters. So we want to get those catheters out. So we give them a form, teaches them how to take care of it, who's allowed to use it and who's not allowed to use it, and all the restrictions. And we also advise them strongly to go to the surgeon to get an access place, because they tend to like a catheter once they learn that they need needles. They have to be put on dialysis with needles and an access in their arm. So we actually have them sign it just so that they're engaged and that they're willing to be informed about it. That's something we did.
So it's a signed like acknowledgement that they've been taught?
Exactly, that we reviewed it. And then it also is for their reference when they're at home, similar to this. So it gives them, they can be reminded, because at this point they're just starting dialysis, and there's a lot coming at them, and there's a lot of stuff they're taking in, so they may not know how to take care of the catheter after, which they don't really have to. So,
is that something you'd be willing to share with others?
Sure.
If you can either send it to me, or you can drag the document into the chat box area, whichever you're more comfortable with.
I'll scan it and send it to your email.
All right. Thank you.
What is your email?
It's the one that the calendar invite came from, DEB.
Okay, I got it. All right, super.
Here,
Sure will.
In the chat box too. Thank you. That sounds, and how are your patients reacting to that?
I think that they really like it, just because then they have something to reference, and also the family member has something to reference, because just the anxiety of getting a catheter, starting dialysis, all of that coming at them, they may not really understand, even when we're talking to them and teaching them. It's just another tool to reinforce.
So have either of you, Ginny or Bakula, asked patients or family members, how do I say this, to critique the documents you give them? You know, health literacy issues, reading, medical jargon. Have you gotten any input from your patients and families and the document itself?
Have not, and I just started this 2 weeks ago.
Okay, well that's great you've started it, but you know, a whole nother aspect of patient and family engagement, or person and family engagement, getting their input on work that the practice or hospital is doing. And so I would just suggest that you might want to ask some of them who are, you know, tracking it well and maybe a little further along in their care, if there are ways that you might improve upon.
Sure.
My feeling is from our patients, because they're mostly elderly and caretakers, may not get so much success in their feedback in writing, but I think verbally it will work with it. And the other thing we added is especially the blood pressure, because a lot of patients had an uncontrolled blood pressure issue. So what we are suggesting now, mostly everybody has blood pressure monitor, electronic at home. We ask to at least 1 or 2 reading and keep a note of it, and then their next visit. So that is very successful we have, because that reading of their blood pressure or like from previous visits. So at least 2 blood pressure randomly taken, and that really helps adjusting the medication, the blood medication.
Mm-hmm.
That we added are like into our one of the goals
Right.
to control.
You know, I'm reminded of a couple of things from what you've said, Bakula, as well as Ginny, what you've said. One, there's later on in the agenda, you'll see there's a link to a webinar that talks about medication safety, and there's a speaker on that webinar who is at high risk for blood clots. In fact, survived 2 pulmonary embolisms. He describes this on the webinar and makes a point, Ginny, this speaks to what you were saying, of makes a point of the fact that when a patient is in crisis, whether it's, you know, trauma or something in the ER, or in the case of dialysis, having to understand all of this new information all of a sudden, they're not going to hear it the first time, nor will their family, because their family is emotionally involved and upset and trying to figure out what's going on themselves. So your point, Ginny, about having to repeat things and have it in writing, I think really needs to be underscored, whatever the situation, when a patient is trying to take something new in. And Bakula, when you and I first spoke last week about what you were doing, I shared with you something I did for my mother when she was still alive and living in one of those senior centers, still in her own apartment and having to manage her own meds. So for those of you who are nurses who have worked in a hospital, you know that medication administration record that we always had to complete, and it's even, you know, in the automated systems now. I just made one up for her on paper, and that's something I'll distribute around with the minutes. And she kept it on her kitchen counter, and I had little icons on it so she knew which were morning and which were afternoon and which were nighttime meds. And she actually used it quite religiously to check off when she took her medicines. And so it was, you know, kind of her own self-medication administration record that kept her compliant and correct with what she was taking. So it's something that you can easily create a blank form and handwrite it in or whatever, print it in or not, but I will share an example of it around with the minutes, all kind of in that topic area of self-medication management, which of course is one of these PFE metrics as well. Other thoughts, other people doing things, wanting to hear more? Janelle, you've asked if we can cover radiology in the future. We will. We'll put that on one of the next agenda items, and maybe you can share with us some things that you are doing or would like some input around. Okay, and Bakula, I can send this document around with the minutes for people to see and maybe use as a basis for what they're doing, or I think you indicated to me that would be all right when we spoke last week.
Yes, yes, yes.
Okay. So thank you very much for sharing that. We hope others will do the same. As you can see, I didn't ask her to create slides or get anything real fancy. So we just want, you know, to hear from everyone and learn from each other.
Yes.
Okay, so trying to stay true to keeping this a little shorter so you can get back to your patients. Just wanted to tell everyone that we're going to repeat that survey that we did in November, as well as the opioid management survey. We're going to try and reduce the opioid management one in length. It got a little detailed in some parts. Many of you are new and never completed the first one, so you'll see these are kind of quick. It's a SurveyMonkey thing. We just ask for you to respond so we can track how, as a group, you're moving along with implementing changes for both of these types of activities. Also, by way of reminder, there are lots of resources on the Patient-Centered Primary Care Collaborative website. They are one of the original support and alignment networks for the TCPI effort. And this is the webinar I was referring to earlier. It's about 54 minutes. It covers information about setting up person and family advisory consults, medication management, and the use of e-tools with patients. So there's like 3 PFE metrics built into this webinar. The one speaker from Providence Health talks about how, as a health system, they set up multiple ambulatory care center person and family advisory consults. It's kind of interesting to hear the approach they took. Lots of volunteer patient and family members. Another gentleman, the one who survived a double pulmonary embolism, talks about medication management and how the patient needs to be taught and involved and engaged. And then e-tools are discussed and how they can be used to enhance communication and patient engagement. So the link to that webinar is the second one in this agenda item. That first link is where you can access all kinds of other resources that they've put together. So when possible, we're going to refer you to these links rather than create all kinds of new documents, because these are ready and available for each of the PFE metrics. Again, of course, there's also the healthcare community website. Those of you who are new may not have registered yet, but besides PFE, there's all kinds of other documents here. So again, we encourage you to get registered there. Our next meeting is scheduled for the first Wednesday of April, which I believe is April 4th. That is a heavy spring break week. So we're thinking of rescheduling that one to the second Wednesday of the month, to April 11th. I would like a sense for those of you who are on as to what preferred topic. We can go right into motivational interviewing, likely with a guest speaker, to talk about what this is and how you use it to help activate the patient, get them more involved in decision making, and helps tune you in to where they are as it relates to making necessary lifestyle changes. The second topic that many of the respondents to the survey in the fall said they wanted to hear more about was patient medication management. So you can say something in the chat box now or email me. If we don't hear from you within a couple weeks, we'll just kind of make the call on what the topic should be and keep the process moving. So again, please watch for the email with the survey link. It'll come from me, but also show up in the newsletters. And on that note, on the newsletter note, we hope that you all received, you might have received it twice, a copy of a special newsletter on MIPS and the 2017 requirements. Everything's due by March 31st, at which point CMS will close their data submission portal, and whatever you've entered is what they consider final. So if this is sounding like news to you, please email me or Ivan or Eddie and we'll walk you through it. But hopefully you all got that email yesterday, and in the very near future we'll be sending you more information about what you should be doing for 2018, because some of the rules have changed in terms of expectations. Specifically with quality, you should be collecting data for at least six measures. You can do more than that, of course, and it should be for a full year. So the clock has already started for 2018. Any comments, any thoughts, questions anyone has?
And then what about the bundle, the application for the bundle?
Yes, there's a new set of bundles out now, most of which pertain to the inpatient setting, but there's some that are more cardiology focused in the outpatient setting. The thing about this new bundle is that you You have to fill out an application by March 12th. And again, in one of the last newsletters, you'll find information about this. Not the special one that went out yesterday, but last week's. Filling out an application is non-binding. However, the next window for applying for this round of bundles may be 2 years from now. So here's how it works according to what CMS is saying. You fill out the application. Between now and July or August, they're going to finish their plans for how all of this will cost out. They haven't finalized how they're going to pay yet for all these new bundles in this latest coordination care set of bundles. So you can fill out an application. It's non-binding. In July or August, they say, you'll hear back as to whether or not your application is accepted, meaning, you know, it's relevant and you're ready for this kind of advanced payment model. There'll also be more information about how they intend to pay, at which point you can say, yes, I'm in, or never mind, I'll wait for the next round of invites. So the key date here is March 12th. So look this over. We understand the application is a little lengthy, so you might want to take a look at it soon. Look at last Tuesday's newsletter that came under Jana Eller's email address. You'll find more information about that. We'll try to help you if in the meantime you do have some questions. We do hope that there'll be more APMs cropping up in this next year as more and more practices are ready and need one that's relevant to them. Otherwise, if you are remaining in MIPS for another year, just keep working on your quality performance, your improvement activities, and the advancing care information measures that are listed and available on the QPP website. We'll keep you moving on it too. That's part of what our role is in the TCPI project once you participate with us. All right, Ivan, any comments you want to add?
No, I think you captured all of those points well, and I thought there were very good discussions from the practices. Thank you, Debbie.
Okay, and one last question here from Steve Dixon. Well, a couple questions. One from Steve. If practices join the bundle and associated with APM, will that status move us out of the VCSQI initiative? Yes. Once you officially join an APM, you are considered graduated from the TCPI project. And we will say, nice job. Thanks for being part of it. From Mary, wondering if there is a survey readiness checklist that someone can share. What type of survey readiness are you talking about, Mary? I'm not sure.
Any type, like the Joint Commission or any of those.
Oh, that kind of survey. Those are my old stomping grounds. I came from JCR.
It's changed so much. When you're not in the hospital, it's so hard to keep ahead of that.
Yeah. I don't know if anyone has any. So you're talking about ambulatory care, though, surveys?
Yeah.
Like AAAHC and Joint Commission.
Yeah.
Okay, well, we'll put that out. Jana, maybe we can put that question into the newsletter, asking if any of our participants have some guidance to each other on being ready for, and that's an accreditation survey, right, Mary?
Thank you.
Yeah, okay.
Just send it to me. I'll be glad to include it.
All right, I'll send you some text for that.
Thank you.
All right, thanks everyone. Have a good rest of the week. And again, if you've got thoughts about what you want covered on April 11th, I'm going to send a calendar change just for that 1 month to the second Wednesday of the month. And please just email me. And of course, in between, Ivan's there for you. I'm there for you. Any questions you have, and watch for the SurveyMonkey link, please. All right.
Thank you.
Have a good rest of the day.
Bye.